So good morning, and just like to thank the Primary Care Rheumatology Society for inviting me to give this talk. Now, I'm not a gout expert, so bear with me. So what I would say about gout is it's really common. We see gout in secondary care rheumatology, we see gout in primary care. There's a lot of gout in the community that really probably doesn't bother us too much in the health service. But I think, I'm being honest, I don't think anybody manages gout particularly well. And this idea that all gout needs to be managed in primary care is very challenging. So I thought I'd try and put together a review of gout and talk perhaps more from a practical point of view about treatment and management. Instead of a toolkit, I'm not sure whether you're going to come away with a toolkit. I was going to make my slides really, really beautiful, but I spent most of yesterday racing around after a baby seagull that fell into our garden, and the cat was trying to kill it. So this is kind of an overview of what I'm going to touch on. It's a little bit of a kind of a what is gout, epidemiology, and then I'm going to talk about acute gout management, preventing gout, and then I'm briefly going to finish with some clinical challenges we all face when treating patients with gout. So what is gout? It's an inflammatory arthritic condition. It's caused by deposition of monosodium urate crystals in the tissues, around the joints and in the joints and elsewhere. And it causes excruciating pain, heat and swelling, which can last for days or weeks. It classically affects the first MTP joint. Certainly with the first attacks, that's the most obvious joint that's affected. And that's largely because that's one of the joints we start to develop osteoarthritis in first. We walk on our feet. Gout loves osteoarthritic joints. It's the most common inflammatory arthritis and is increasing in incidence and prevalence around the world. And it was described in the 1840s by Sir Alfred Garrett, who linked gout with high levels of urate in the blood. And we've got a very inflammatory cell that's ingested a urate crystal here, and it's causing lots and lots of inflammation in response to that ingestion. So these are monosodium urate crystals. They're seen under polarized microscopy, and they're quite pretty, aren't they? I'm not going to go into too much detail about that. So urate is a metabolite of purine, and in its ionized form, it kind of forms crystals at different pHs. Sorry, I've made my slides too small. Most of the urate's excreted by the kidneys, but some of it's excreted by the GI tract. And high levels of urate, hyperuricemia, is the most important risk factor for developing gout. The level of urate directly correlates with the risk of disease, so actually getting the urate down can actually prevent people from getting gout. But some people will have high levels of urate but never get an attack of gout. And some people can have an attack of gout. You measure their serum urate and it's within the normal range. And you're thinking, well, it can't be gout because the urate's normal. Often that urate level will rise back up after the acute attack of gout has finished. Most people with hyperuricemia have reduced excretion of urate. But about 10% of people who have hyperuricemia, it's because they actually produce too much urate. This is back to medical school or biochemistry. So purines are kind of obtained from the diet. So high purine foods are the kind of the high levels of protein in the diet, the offal that we don't really eat very much nowadays, but can be produced by de novo synthesis. And uric acid is the end product of purine biosynthesis. So as we break down our proteins and purines, we have these enzymes, xanthine oxidase, that break down purines to produce uric acid, which is then excreted from the body via the urine. So I mentioned before that most hyperuricemia is due to underexcretion, and that can be just primary underexcretion or it can be secondary to other things. So we've got impaired renal function, so a low EGFR. We've got the effects of drugs, so the thiazide diuretics are really good at reducing our urate excretion. And then we've got the effect of aspirin, which I'll touch on in a bit more detail later, and some other drugs. And alcohol reduces urate excretion. And then we've got the effects of other things like ketones and lactate, and then other things like hypertension and dehydration. And then we've got overproduction, which is less frequently seen. We sometimes see this in people undergoing treatment for malignancy or very, very active psoriasis with lots of cell breakdown. It increases their purine levels and leads to hyperuricemia. But overproduction is associated with obesity and high triglycerides. And rapid weight loss I've put in there because we've seen a few people who present with gout after undergoing weight loss surgery. They get very, very accelerated weight loss, cell breakdown, and end up with hyperuricemia and gout. This is the natural history of disease. So we start off with hyperuricemia, which can exist for many, many years and never lead to an attack of gout. Then over time, some people will go on to get an acute attack of gout, and if that's left untreated, they will likely go on over years to develop this intercritical gout where they'll get recurrent episodes of gout, and then they'll eventually develop chronic tophaceous gout. So epidemiology of gout predominantly affects men within working ages, but can affect postmenopausal women. There is still an increased male to female ratio, and the prevalence of acute attacks of gout rises in both genders up to the age of 80, where it plateaus. And the global prevalence of gout ranges from 0.1% to 10% in the adult population. And an attack of gout has a significant effect on both quality of life, ability to work, and places huge economic burden on the healthcare system worldwide. And as I mentioned before, the incidence is rising. A recent, well, not very recent, but a study from the UK General Practice database in 2015 showed the prevalence of gout had doubled from 1999 to 2012. And there's geographical variation, so there's a very high incidence in the New Zealand Maoris, but a lower incidence in Aborigines. And there's a very high incidence in Taiwan. Other risk factors are important and probably go largely to explaining the higher prevalence of gout. So we've got CKD, the cardiometabolic risk factors, osteoarthritis, lymphoproliferative, myeloproliferative disorders, and severe exfoliative psoriasis. And postmenopausal status in women is really important, and obviously the prevalence of gout gets higher as we get older. So how do we assess gout? So an acute presentation, I really like this quote. So if you screw up the vice as tightly as possible, you have rheumatism. If you give it another turn, then it's gout. So it just highlights how painful an acute attack of gout is. It typically starts with a monoarthritis. Most commonly affects the first MTP joint, and this is called podagra. People get excruciating pain, swelling, redness. They can get a low-grade pyrexia. Their inflammatory markers are elevated, and it mimics a septic arthritis. Each attack usually lasts 7 to 10 days, and it will resolve completely, and the joint goes back to looking the way it did before the attack started. The uric acid level can drop in an acute attack, and it really favours the damaged joints. Here is a picture of acute on chronic gout. You can see there's a tophus, but also an acutely swollen right hand with the appearance of dactylitis. And I think that's the other thing to remember, that gout can cause a dactylitis, which can sometimes be confused with a psoriatic arthritis. And then late stages of gout, you've got your chronic tophaceous gout, this checking the ears, like we were always taught at university, to look for these chalky deposits of urate. They're usually subcutaneous, they're usually at extremities, so cold may induce attacks of gout and urate deposition. But they may occur anywhere, and they're seen in heart valves, eyes, ears, even within the spine. So this is from the NICE guideline in 2022. So suspect gout in people presenting with rapid onset, often overnight, of severe pain, together with redness and swelling in one or both first metatarsal joints, or if they've got tophi. And then consider gout in people who present with rapid onset, often overnight, of severe pain or redness or swelling in the first MTP joints. And then always think about the possibility of septic arthritis, because it's actually very difficult clinically to tell whether somebody's got septic arthritis or gout. But if obviously they've got a history of gout, they feel it's their gout, it's more likely to be their gout. But always think about, well, could this be septic arthritis? And then consider chronic gouty arthritis in people who present with chronic inflammatory joint pain. To make a diagnosis, measure the serum urate and look for an elevation. If it's below 360 micromoles and a gout during a flare, gout strongly suspected, repeat the urate measurement at least 2 weeks after the flare is settled. And then consider joint aspiration to get the gold standard diagnosis if they've got evidence of urate crystals. And then if you're still uncertain and joint aspiration doesn't yield crystals or the patient can't tolerate it, consider imaging, so with X-ray, ultrasound, or more recently, dual energy CT, which I've never been able to obtain from our hospital, so I don't know if anybody else has ever heard of this. It gives beautiful pictures, and it's very good for determining a gouty arthropathy. So the diagnosis of gout made on clinical grounds, but also radiographic appearances in chronic gout. You get these punched out erosions with sclerotic edges. Musculoskeletal ultrasound is really good for diagnosing gout. You get crystal deposition across the cartilage. You get this double contour sign. And then this is an image with the green gout crystals showing up, which is really sensitive for monosodium urate crystals. So this is dual energy CT imaging DECT. So again, this is from the NICE guidelines. Treatment for gout flares, offer an NSAID, colchicine, or a short course of oral corticosteroids, taking into account the person's comorbidities, co-prescriptions, and preferences. Add a proton pump inhibitor for people with gout who are taking an NSAID to treat a gout flare. Consider an intra-articular or intramuscular corticosteroid injection to treat a gout flare if NSAIDs and colchicine are contraindicated, not effective, or not tolerated. And advise people with gout that applying ice packs to the affected joint, in addition to taking prescribed medication, may alleviate pain. I don't think I've ever recommended anyone apply an ice pack, but it's there in the guideline. Sorry, I'm reading them out because the NICE guidelines speak is very specific, isn't it? So prescribing in acute gout, this is trying to put a little bit more meat on the bones from the NICE guidelines. So if the patient is already on urate-lowering therapy medication for chronic gout, do not stop it. Continue it, even if they've got the most hideous attack of gout. NSAIDs, any high-dose NSAID will do, but you do need to provide PPI for gastroprotection. And then start as early as possible. Avoid, obviously, in renal impairment and cardiovascular disease, which I would say for most of my gout patients rules out NSAIDs. So I don't find NSAIDs particularly useful. This is Liverpool, John, for managing acute attacks of gout. And then oral prednisolone. Everyone uses a different oral prednisolone dose for treating acute gout. I tend to be really cautious and tend to use 10 or 20 milligrams daily for 5 days, but a lot of my colleagues use higher doses for shorter periods. There is no clear trial that says what dose of prednisolone should be used. And then colchicine. Colchicine, 500 micrograms twice daily, or QDS, is effective management for an acute gouty attack. we tend to use a lower dose in the elderly or people with renal impairment. Start early, it's more effective if it's initiated early. So again, this rescue pack at home is really helpful. It reduces inflammation. Unfortunately, colchicine has adverse effects, the most common of which is diarrhea, which is very dose dependent, but it can cause bone marrow suppression, myoneuropathy, a drug-induced myositis. Be careful, older copies of the BNF refer to much higher dosing of colchicine, which is no longer recommended. And I think they talk about taking 2 tablets immediately and then another tablet every 2 to 3 hours. And we've certainly seen very sick patients on the wards with extreme diarrhea and renal impairment secondary to colchicine-induced horrible diarrhea. So offer a follow-up appointment after a gout flare has settled to measure the serum urate level, provide information about gout and how to self-manage and reduce the risk of future flares, and then assess lifestyle and comorbidities, particularly cardiovascular risk factors and CKD, and then review medications and discuss risks and benefits of long-term urate-lowering therapy. So, when do you start urate-lowering therapy? I think that's always the challenge, isn't it? We would recommend urate-lowering therapy for people who have gout, who have multiple or troublesome flares. And I would say if your first attack has brought you into hospital, that's a troublesome flare. And I would always try and encourage the patient to take urate-lowering therapy at that stage. If a patient's got chronic kidney disease, is on diuretic therapy that can't be stopped, or if they have a chronic gouty arthritis with tophi, they should start urate-lowering therapy to protect their joints. The NICE guidelines recommend starting urate-lowering therapy 2 to 4 weeks after a gout flare has settled. I would often start it at the gout flare, but I would add prophylactic treatment to prevent worsening of the gout flare. That's really, you've got the patient, certainly in hospital, we've got the patient in front of us. They're experiencing the awful pain. They're much more likely to take a medication to prevent a further attack at that point. I think catching up with them in the future, often we don't see them again until their next flare. So discuss with the person, this is from NICE guidelines, the benefits and risks of taking medication to prevent gout flare. Advise the patient that urate-lowering therapies are lifelong medications. They're not a course of treatment. And for people who choose to have treatment to prevent gout flares, offer a prophylactic treatment to prevent a urate-lowering therapy-induced gout flare. So we'd often co-prescribe colchicine, 1 tablet daily, or an NSAID if possible, or a low-dose oral corticosteroid. Urate-lowering therapies that we tend to use are allopurinol and febuxostat. And when you initiate therapy, because the urate level drops, that can actually precipitate an attack of gout, hence the need for these prophylactic treatments. The other urate-lowering therapies we tend to use less frequently, so the uric drugs. I don't think I've ever prescribed probenecid or sulfenperazole, but we do use benzbromarone, but it's a hospital-only prescription because there are concerns over hepatotoxicity. And then we've got to be mindful of the pleiotropic uric drugs. So you may be able to adjust the patient's medication to achieve urate lowering, in addition to using a standard urate lowering therapy, so the losartan, the gliptins, and fenofibrate. And then we've got these very expensive uricolytic urate oxidase drugs, which tend to be used for preventing gout in patients undergoing treatment for myeloproliferative disease. We recommend a treat-to-target approach, and I think this is something that is filtering down. So we need to get the urate level down to a target level to prevent the patient from having attacks of gout. And so it's this quite intensive, every month check the urate. If it's not at the target level, you need to increase the urate-lowering therapy. So target level of 300 micromoles per litre for people with gout who have chronic gouty arthritis or have recurrent attacks of gout. And I think EULAR made the recommendation that the urate level can be at 360 micromoles per litre in stable patients. So when the target's achieved, we would recommend an annual review to check the urate stays at that target level, but also use it as an opportunity to assess cardiometabolic risk factors. And this is what I say to patients, which I don't know if does anybody else know the box of matches analogy for gout treatment. I think one of my previous rheumatology tutors taught me this. So if you think about hyperuricemia being lots and lots of matches stuffed all around the body in the joints, urate lowering therapies are your hand going in and taking the matches out one by one. And eventually, over time, the matches will be gone and they won't be at risk of attacks of gout. But actually putting your hands in the box of matches to rumble around trying to find the next match to remove, you're much more likely to make those matches catch alight. So starting a urate lowering therapy, bringing the urate down, can cause acute attacks of gout. The prophylactic treatments, the colchicine, the NSAIDs and the steroids, are effectively pouring water on the matches to make them less likely to catch alight as they're being removed. So that's how I explain to the patients they need to take 2 medications, at least for the first 3 to 6 months of urate lowering therapy. So these are questions that patients often ask. What about diet and gout? There's lots on the internet about this. So NICE explain to people with gout there's not enough evidence to show that any specific diet prevents flares or lowers serum urate levels, and advises them to follow a healthy or balanced diet, and advises them to try and get their excess body weight down and to reduce obesity. As obese patients tend to have more severe gout, they often present earlier with their first attack of gout. But when I looked at the evidence, there is some sparse or fairly weak evidence for tart cherry extract. It does reduce serum urate and frequency of attacks if taken regularly. And then things about the diet to be mindful of. Fructose, having high fructose in your diet can lead to high levels of purine and hyperuricemia. And high fructose corn syrup, which is kind of in all your ultra-processed foods, is important to be aware of. And then alcohol reduction. So we advise patients to reduce their alcohol intake. Beer particularly has a high purine content, and patterns of alcohol drinking are important to be mindful of. So the binge drinking pattern, you'll get fluctuating urate levels and be more at risk of gout. What about aspirin and gout? So aspirin can increase your levels of uric acid in the blood through reducing excretion of uric acid through the kidneys, but it's very dose dependent. This typically occurs when aspirin is taken at moderately high doses, which isn't a dose that we tend to use in the UK. But low dose aspirin will have some modest effect on blood urate levels and will increase attacks of gout in patients with known gout. Very high doses of aspirin act a bit like an NSAID, and a high dose NSAID, and actually reduce blood urate levels. But again, we wouldn't normally use very high doses of aspirin. So how do we best manage acute gout and chronic kidney disease? Everybody's getting chronic kidney disease as we age. So NSAIDs are contraindicated. Corticosteroids are probably relatively safe, but there's obviously a caution in hypertension and diabetes. And colchicine, can we use colchicine in chronic kidney disease? So there's a lot of evidence that colchicine at the standard dose of 500 micrograms daily can be associated with colchicine toxicity, and this is a scary rhabdomyolysis, which I don't think I've ever seen, neuromyopathy, or bone marrow suppression. And the renal physicians tend to recommend if we need to use colchicine, we use it at a lower dose, so 500 micrograms alternate days or twice weekly in people with very impaired EGFR. And this is, you can have these slides afterwards if it's helpful. This is from a recent review of gout in the kidney, which I thought was really informative. And it's just an overview of the drugs that can be used in CKD for managing flare and also for prophylaxis. So anakinra isn't a drug that we have easy access to. It's still fairly expensive, but it is effective for managing the very difficult flare of gout in a chronic kidney disease patient, but that would be in hospital. And then urate lowering therapy in chronic kidney disease. Again, there are tweaks to how we manage this. So allopurinol can be used in CKD, but you're much more likely to get allopurinol reactions if you start with a higher dose of allopurinol. So recommendations are to perhaps start with a 50 milligram dose of allopurinol and titrate up following a treat-to-target protocol. And, doses of 300, 400, 500 milligrams of allopurinol can be used in CKD as long as you're monitoring their kidney function and their urate level. But start low and gradually increase. And febuxostat, again, effective and safe. It's been pushed as a safe drug for moderate to severe kidney disease, but the ACR recommends starting at a lower starting dose than usual, which would be a 40 milligram per day dose. And in the UK, you'd have to break the tablets in half to do that because they're 80 milligram tablets, and increase following a treat-to-target protocol. And benzbromone, again, I mentioned this is a drug we use in hospital that can be used in patients even with quite impaired creatinine clearance. So it can be an option to refer in for difficult to treat gout. And this is again from that same paper summarising urate lowering therapy in chronic kidney disease. And then urate lowering therapy in cardiovascular disease. So we all got very, very upset when febuxostat, which we could use in these difficult comorbid patients, suddenly had a black box warning attached to it after the CARES study secondary analysis suggested that there was a higher risk of death with febuxostat than allopurinol. So a more recent study looking at the long term, so it was specifically set up with a non-inferiority trial design to look at the long-term cardiovascular safety of febuxostat compared to allopurinol in patients with gout. And this was particularly set up with an endpoint of looking at cardiovascular and mortality outcomes, and they found that no increased cardiovascular death compared to patients on allopurinol was observed in patients with gout treated with febuxostat. And the febuxostat patients actually had fewer deaths when compared to those patients taking allopurinol. So I think we can probably feel a bit more comfortable about using febuxostat in patients who have known cardiovascular disease. I'm nearly finished now, you'll be glad to know. So this is a summary slide I made for some medical students, and I really like it. So gout, the great toe, first MTP joint, the O, one joint only usually at the start, uric acid is raised, and patients have tophi. And the treatment is treat the acute attack, treat the hyperuricemia, but always address lifestyle changes and cardiometabolic disease, which go hand in hand with gout. And thank you very much for listening. I hope I've not overrun too much.
Thank you, Nicky. Thank you. Can you hear me? Yes. Anyone got any questions for Nicky? Yeah, we need to use the microphone.
I note your advice about putting something cold, the NICE guidelines advice about putting something cold to help during an acute attack, and I can understand the analgesic effect because it can be used for analgesia before injections and so on, can't it? But as a general rule, it was my understanding that areas that get cold are more likely to get precipitation of the crystals. It would be important, I think, to point out to patients that they should avoid cold peripheries and so on. Would that not be right?
Yeah, I suppose the acute attack with the advice to use cold for pain relief, I don't think you're going to necessarily get tophi after 2 or 3 days of using a cold pack intermittently. But we don't suggest people wear earmuffs to prevent tophi in the air. We'd much rather just treat their hyperuricemia to bring their urate burden down to prevent tophi formation. So it's not, we don't tell people to wrap themselves up with scarves and hats all the time.
I just wonder though whether we ought to, because I still help with prosections in the anatomy department over in Hull, and I can distinctly remember one lady who obviously had bad hyperuricemia, and every single joint, every single bursa, when we dissected her, she was a cold body, was full of crystals. All of these structures were white, and I would have thought these are all potential places for setting off an individual attack. I mean, one of the reasons that attacks start in the fingers, great toe and tophi on the ears and so on, I believe, was because these areas tend to be periphery in the coldest parts of the body.
Yeah.
Just a thought, isn't it?
Yeah, no, a really interesting idea, isn't it? Yeah. I really like the idea. Sorry, I'm going to. The idea that your feet get cold at night and you wake up with gout in your big toe is quite a nice one, isn't it? One of the things I think is really interesting is the association between waking up, feeling well, going to bed, and then waking up with an acute attack of gout. What is it that happens overnight? And there have been some hypotheses that dropping your level of oxygen if you've got sleep apnea can actually lead to cell death, increase your purine, hyperuricemia, and cause an acute attack of gout. But I'm sure there are lots of other explanations for that. Why do you wake up with this awful, awful onset when it wasn't there the day before? You've had no warning it was going to come on. I think and it may be, some cold, your peripheries are getting a little bit cold in the bed and you're more likely to get an attack because of that. So I think that's really interesting. Sorry.
Hi. I was just wondering really what your advice is on patients with asymptomatic hyperuricemia. It's always a little bit of a tricky, when do you intervene, and kind of,
the guidance at the moment is asymptomatic hyperuricemia you don't treat. It's always very tempting, isn't it, when you see somebody who's got a really elevated urate level to jump in with urate lowering therapy. I think on one of my earlier slides, 95% of people who have hyperuricemia will not go on to get an attack of gout in their lifetime. So you'd be committing somebody to lifelong medication that may not be of any benefit to them. But obviously, you'd use that opportunity to assess their cardiometabolic risk factors, and you would, encourage them to lose weight, exercise, target, triglycerides, and if they've got diabetes, and manage their blood pressure. And that may well actually bring their urate down. I think of it as a kind of just a cardiometabolic marker. Yeah.
How related are attacks of gout to food items? When you get patients say, well, I have strawberries one day, I get an attack of gout the next day. Is that feasible, do you think?
It's really difficult, isn't it? I think any dietary study that shows a clear trigger I always find dietary studies so difficult because we're all so different. The way we process our food is so different. Our microbiome is so different. So, if somebody always gets an attack after they eat strawberries, it doesn't mean the person sitting next to them is going to get an attack after they eat strawberries. So I find it very difficult to give advice to patients. We certainly see in rheumatology people who say, I can't eat tomatoes because they've caused my rheumatoid arthritis. They're acidic and they cause acid in the joint. That's never been proven, but it's something I still get from some patients. So I think everybody's so individual, and how we process our food is so individual. But the only, the idea that eating berries actually have, not so much strawberries, but berries actually have a slightly lower sugar content, so they're relatively healthy for a person who has gout. If you have lots of sugar, lots of fructose, it actually causes your purine levels to go up. And because fructose tends to be stored, it's kind of causing a problem for the future, whereas glucose is broken down immediately. So very high fructose fruits, so apples have lots of sugar in them, but berries are probably a safer option if you're trying to advise people what to take or what to eat to keep healthy.
Can I just ask about the menopausal thing? So you don't see it much in premenopausal women, so presumably that's estrogen.
Yeah.
And does anybody know in what way estrogen is protective, and do women on HRT get less gout, and would you ever recommend it as a treatment?
I don't think you'd recommend it as a treatment, but I think that's a really good point. So I'm not up to date with that literature, but HRT does seem to reduce presentation with gout. And sometimes we do see people presenting with a nasty attack of gout after they've stopped HRT that they might have been on for years. So I think there is an effect, but this is eminence medicine rather than evidence medicine. And I think there probably is evidence out there, but I'm not up to date with it.
Sorry, with regards to you mentioned about the injections, because in the FCP clinics we have acute patients come in, most of them manual workers, and they say we can't afford to be off work. And they say, can you give me an injection? Will it work quicker and make me get back to work quicker? What are your thoughts about that?
I think that's great if the patient's willing to have an injection. The only thing I'd be mindful of is are you going to inject steroids into a potentially infected joint? So you need to be fairly confident that you've made the diagnosis that this is an acute gout attack. So yes, the injection will probably help quickly, but so will, you know, a short course of oral steroids or an intramuscular steroid if you didn't want to inject into the joint, or obviously NSAIDs or colchicine if they can take them.
So to go on from there, do we send the patient to then, for some patients I don't want to take medications, I want an injection. So would you say that we're going to rule out the infection first before we inject you, or what's the way to go forward?
I think in a patient that you're convinced that this is an acute attack, then you can inject into the joint, but it is difficult to separate out whether this is infection or an acute attack of gout. We all find that difficult, certainly in hospital. But it's, you know, it's a clinical assessment. But you can inject into the joint if the patient will let you.
You mentioned earlier that cyclosporine can precipitate gout. I mean, it's very rarely used now as an old-fashioned immunosuppressant. I've seen a couple of patients on tacrolimus, liver transplant, renal transplant with sirolimus. Is there any evidence that some of these more modern immunosuppressants can precipitate?
I think they will also reduce your urinary excretion of uric acid, so you may be more prone to hyperuricemia.
Couple of questions regarding prednisolone and colchicine. Is prednisolone better than colchicine? And if the patient coming with multiple flare-up, can we give both colchicine and prednisolone at the same time?
You can do, but what I would do is, in that situation, I would reserve your colchicine for your prophylaxis, because that patient needs to get their urate down if they've got really bad gout. And I would use the prednisolone to treat the acute attack and get that patient started on urate-lowering therapy or increase their urate-lowering therapy with colchicine cover. So give allopurinol and colchicine.
And as alternative to allopurinol, what do you advise, like at the second line, probenecid or febuxostat?
If they can't take allopurinol,
yeah,
I would use febuxostat. I don't like the uricosuric urate-lowering therapies.
Just a quick one. Can you kind of recommend some resources that we can signpost patients to when they've been diagnosed with gout? Just to kind of, because I'm conscious that we bombard them with a lot of information and they need to kind of go away and maybe look at some of the stuff. So what's reliable?
The Versus Arthritis Gout leaflet is actually quite good. So I really like the Versus Arthritis patient leaflets. I think it's written quite well. It's quite sensible. NICE has a nice summary for patients. And there's an awful lot on the internet. Some of the American stuff is a little bit dodgy, and obviously everything's a bit confusing. Sorry, this is recorded, isn't it? I'm probably going to be banned from travelling. But there's quite a lot of stuff out there. There is a UK Gout Society, isn't there, which has some resources, and they're very patient-focused society. So it's probably worth pointing them towards NICE in the first instance, or give them a Versus Arthritis leaflet, and you can download those from the website.
Hi, Nicky. Thank you for your talk. I read somewhere about low uric acid or urate levels having a neurodegenerative risk factor. Is that something you regularly sort of advise on patients in terms of adherence to allopurinol and urate-lowering therapy?
So is your question at very low urate level?
Yeah, or what levels is, sort of neurodegenerative risk factor? Is it below 300, and do you sort of typically advise patients on that?
It's not something I'm very aware of. I think if somebody's urate is like 170 and you've got them on 400 milligrams of allopurinol, you could titrate the dose down, just keep them below 300, and it'll protect them from having further attacks. But it is a difficult one because it's a lifelong medication, and so I think it's the importance of measuring the urate. Now, I have got a case that I saw recently. His man who's got really difficult to treat gout. His urate level is always like 600 and something, really nasty attacks of gout. We've cycled through high doses of allopurinol, we've cycled through top doses of febuxostat, and he's been on benzbromide, and we can never get his urate down. And so he was on febuxostat, back on febuxostat, urate was still 600, 700, and we added in a small dose of benzbromide to try and get him down to target level. And I thought, well, he's still not responding, and most patients do respond to treatment. So with our new IT system, we can look at the GP records, and when we looked at his prescribing, we were prescribing the benzbromide. GP was prescribing the febuxostat, but he was only picking it up every 3 months. So check the patient's taking the medication. Okay.
Lovely.
Thank you very much for your questions.